Good afternoon, everyone, and welcome to National Public Health Week. This is the 30th anniversary of National Public Health Week, and this year we're looking at opportunities to improve rural health in rural communities. I'm Don Simpson. I'm very privileged to serve as a program director for the Arkansas Colleges of Health Education, the MPH program, and we're going to go ahead and get started. As we get going, I'd like to read a land acknowledgement, then I'll introduce our speaker. And should you have questions or comments, please type them into the chat box and we'll make sure that Dr. Hudson has an opportunity to answer them today. We are on the unceded homelands of Native peoples who have ongoing cultural and spiritual connections to the places we live. We acknowledge and send gratitude to the land and to the people who have stewarded it through the generations. In acknowledging this history, we do not intend a superficial action that somehow releases us from the obligations of righting past wrongs. We acknowledge that we live in a world where privileged peoples have gained wealth by colonizing, enslaving, and oppressing other peoples and communities. We see the ongoing efforts of these practices and policies every day, and we work to be accountable to our part in this history. We each come from a different history. We have each lived a unique life. We bring those experiences to the work we do today. We affirm and celebrate our commitment to the difficult and joyous work we must do to transform our communities into ones built on justice and on caring for each other and our lands. It's my pleasure today to introduce Dr. Brittany Hudson. She's a public health professional and researcher whose career is rooted in advancing health equity and eliminating disparities across the lifespan. Drawing from her diverse background, academic experience, and lived experiences growing up in rural Sequoyah County, Oklahoma, Dr. Hudson brings a nuanced perspective to her work, focusing on the unique challenges faced by historically underserved and rural populations. She bridges theory and practice to advocate for healthier, more equitable futures. A first-generation college student and citizen of the Cherokee Nation, Dr. Hudson was awarded the Cherokee National Scholarship and the prestigious Gates Millennium Scholarship, affording her opportunities to pursue academic and cultural experiences, including studying abroad in Spain. She earned her PhD in Health Promotion Sciences with a concentration in minority health from the University of Oklahoma Health Sciences Center. Her dissertation research highlights the voices of community members and mental health providers in Oklahoma's 13 historical Black towns, providing critical insights and promoting culturally responsive solutions. In addition to her doctoral degree, Dr. Hudson holds a Master of Public Health from Boston University and a Bachelor of Arts from Baylor University. She's actively involved with numerous organizations, and outside of her professional life, Dr. Hudson enjoys activities that keep her active, connected, and engaged. So we're very proud and privileged to have Dr. Hudson with us today, as she talks about characterizing the experience of Black Americans seeking mental health services in rural Oklahoma. Thank you, Dr. Hudson. The floor is yours.
Thank you, Dr. Simpson. Good afternoon, everyone. And thanks also to the AIC MPH department for the invitation, and to all of you for being here as we kick off National Public Health Week. I am excited to share my dissertation research, which explores the experiences of rural Black Americans seeking mental health services in Oklahoma. This work is deeply personal. It's rooted in my identity and the communities that shaped me. I believe public health should reflect lived experience, and my academic and personal journey have fueled my commitment to advancing equity and addressing health disparities in underserved communities. Today, I'll walk you through the 3 studies that make up my dissertation, highlight key findings, and share broader implications for public health and mental health service delivery in rural Black communities. Mental health is a pressing public health issue, especially for marginalized populations like Black Americans and rural residents. Rural Black communities face layered barriers, including systemic inequities, geographic isolation, stigma, and a shortage of culturally responsive providers. Despite high rates of mental health challenges and suicide, research exploring their lived experiences is limited, leaving critical gaps in understanding and care. This study helps fill the gap by offering insights to improve culturally appropriate care, guide policy, and ultimately reduce disparities in mental health services for rural Black communities. I'd like to briefly share some background to this work. Over 46 million Americans live in rural areas where rates of depression and suicide are higher. but access to mental health care is limited by systemic barriers. Black Americans are 50% less likely to receive counseling or treatment despite higher levels of psychological distress, pointing to a significant treatment gap. For rural Black Americans, these challenges are compounded by cultural, social, and structural barriers like employment disparities, geographic isolation, and limited transportation. In Oklahoma, nearly 600,000 adults live with mental illness, yet a quarter don't receive the care that they need. The state ranks fifth in mental illnesses prevalence, and rural areas face especially severe shortages in mental health providers, deepening the crisis. I also want to provide some historical context about the population at the heart of this research, Oklahoma's all Black towns. Established in the late 19th and early 20th centuries, these towns were founded as safe havens for Black settlers, including freedmen from Native tribes. They flourished with Black-owned businesses, schools, and churches, serving as powerful symbols of Black self-determination and community. Over time, systemic racism, economic hardship, and the Great Depression contributed to their decline. Today, just 13 of these historic towns remain, preserving a legacy of Black heritage and resilience. 3 additional towns, Arcadia, Fort Coffee, and IXL, were incorporated more recently and were also included in the study. For my dissertation, I used a 3-paper manuscript approach to examine mental health challenges in Oklahoma's rural Black communities, each with a distinct focus. Study 1 is a scope and literature review that assesses the status of mental health and available services in rural Black communities. Study 2 explores providers' perspectives, identifying key barriers, facilitators, and systemic challenges in delivering care. Study 3 centers the lived experience of the rural Black Oklahomans, including the residents of the Oklahoma's historic all Black towns who have sought or received mental health care services. Grounded in phenomenology, this approach focuses on how individuals make meaning of their experience in their own words, emphasizing the why and the how behind their behaviors and their perceptions. Together, these studies offer community-informed insights to support culturally grounded programs, policies, and practice that address the unique mental health needs of rural Black Americans. So on the left, the social determinants of health framework highlights the conditions that shape health, like education, income, housing, and access to care, grouped into the 5 key domains. And on the right, the socio-ecological model shows how health is influenced across multiple interconnected levels, so individual, interpersonal, organizational, community, and policy. By combining these 2 frameworks, my research explores how social, economic, and structural factors intersect to influence mental health outcomes in rural Black communities, from personal experiences to systemic challenges. So this framework was adapted from the National Institutes on Minority Health and Health Disparities research framework and highlights the intersecting individual, social, and structural factors shaping mental health in rural Black communities. It provides a tool to map how influences affect access to and utilization of mental health services across multiple levels. For the sake of time, I won't walk through every detail of the methodology, but I'll highlight the essentials before diving into the results. So to explore the central question, what is it like to be Black, live in a rural area, and seek mental health services, I conducted 3 interconnected studies. Study 1 was a scope and literature review supported by a medical librarian. We screened over 2,400 articles and included 19 studies relevant to rural Black mental health. Findings were organized using the social determinants of health framework and analyzed thematically and narratively. Study 2 explored mental health providers' perspectives through semi-structured interviews. We identified barriers, facilitators, and systemic needs. Analysis followed Brown and Clark's method using both inductive and deductive coding. A community advisory board supported question development and member checking. Study 3 focused on the lived experiences of rural Black residents, including those from the historic Black towns. Using a phenomenological approach, we conducted 15 interviews and analyzed the data with the same thematic framework from Study 2, again using the social determinants of health domains for structure and CAB input throughout. Across both studies, the CAB, or Community Advisory Board, made up of Black town mayors and field experts, was instrumental in ensuring cultural relevance and community alignment. And I will speak more on the CAB. So although I identify as a Black woman from a rural community in Oklahoma, I knew I couldn't assume automatic acceptance or trust. So recognizing that some community members may be hesitant to participate, I chose a community participatory approach and established a community advisory board. Over the course of about 2 years prior to beginning this project, I attended bi-monthly coalition meetings and conferences focused on Oklahoma's Black towns. This was both strategic and relational. I wanted to learn more about the communities while also allowing the residents to get familiar with me before the project began. The CAB was essential to the integrity and success of this research. Pictured here are 8 of the 13 mayors from the Oklahoma's historic all-Black towns who served on the board. As respected leaders, they opened doors to their communities and helped build trust and relationships. From the start, I approached this work with humility and respect, understanding that trust must be earned. The CAB helped me guide my approach to ensure this was community-driven research, not research done on the community. Let me say that again. They ensured that this was community-driven research and not research done on the community. The CAB was involved in every step, supporting recruitment, distributing flyers, organizing town halls, and promoting the study through local networks. They reviewed interview questions, offered cultural insights, and helped interpret findings in ways that resonated with the community. Their involvement strengthened the ethical foundation of the research and made it more relevant and reflective of lived experience. Moreover, this collaboration empowered local leaders, fostering community capacity for future advocacy and sustainable change. So now that I've provided an overview of the methods used across the 3 studies, let's transition to the key findings that emerged from this research. These 3 studies gave me a layered understanding of what the research says, what providers experience, and what community members live every day. So study 1 focused on identifying and assessing available mental health services for rural Black communities through a scope and literature review. And here are some of the key findings. For available services, community-based and electronic mental health programs were prevalent. Some common barriers, or key barriers rather, financial strain, stigma, and limited mental health literacy. And for facilitators, culturally responsive care, faith-based support, and relevant education. To provide deeper insight, findings were organized by social determinants of health domains, offering a structured lens on how these barriers of facilitators impact access to care. Study 2 explored the perspective of mental health providers serving rural Black communities. Key findings included for programs and services, providers emphasized the availability of government-funded services. For barriers, cultural mistrust, which was often rooted in historical trauma and skepticism toward non-Black providers and government systems, and also legislative constraints that limit access to care. Facilitators, diversity, equity, and inclusion initiatives, community engagement, and strategic partnerships were seen as critical to improving service delivery. And for needs and challenges, providers underscored the need for support, training, and resources to protect their own well-being and sustain quality care. These quotes reflect some key themes shared by providers. One provider acknowledged the deep historical trauma in Black communities, referencing slavery, Tuskegee, and the Tulsa Race Massacre, and noted that even as a Black provider, building trust remains a challenge. Providers emphasize the importance of cultural connection, like understanding phrases such as "I got sugar," which is diabetes, and this helps them to relate more authentically to their Black clients. And then for support, there was a clear call for incentives to help retain therapists in rural areas, similar to what's offered for physicians. And then lastly, providers highlighted the value of open dialogue and personal testimonials in reducing stigma and encouraging others to seek care. Lots of power in storytelling. So study 3 explored the lived experiences of community members engaging with mental health services. Key barriers included stigma, low mental health literacy, and mistrust rooted in historical and systemic harm. Participants also cited a fear of judgment and transportation challenges. Facilitators included faith-based support, trusted community spaces, and culturally relevant education. Social networks help normalize mental health conversations and reduce stigma. A major challenge was cultural inertia, which I define as the resistance to seeking help due to ingrained norms around toughness and emotional restraint. And this was reflected in the archetype like the strong Black woman and perceptions of weakness in Black men. Participants expressed a clear need for culturally informed providers who practice humility and for improved continuity of care within the system. These quotes from community members offer powerful insights into their experiences and perceptions of mental health. For mental health literacy, many focus only on diagnosis, overlooking everyday emotional struggles like stress, sadness, and anxiety. Generational messages like what goes on in this house stays in this house creates resistance to therapy and reinforces harmful cycles. Some felt uncomfortable with providers who didn't share their racial or cultural background, citing a lack of understanding and connection. And then language matters. Terms like therapy can be off-putting. Participants stress the need for culturally resonant language to better engage Black communities. And then lastly, social influence, leading by example, showing personal healing and accountability was seen as a powerful way to reduce stigma and inspire others to seek support. So now that we review the findings, let's transition into the discussion where I'll connect these results to the broader literature. So this table summarizes cross-study findings on available mental health programs and services. While implementation varied, faith-based services, telehealth, and government-funded programs were mentioned across all three studies. Community health programs also stood out as essential local resources. We also identified several unique or standalone services. The literature highlighted culturally adapted interventions. Providers discussed tailored government-funded efforts, and community members emphasized grassroots community-specific programs. And it's important to note here that while these programs exist, the literature reminds us that availability does not always equal accessibility or use, especially in underserved and rural communities. So this table highlights key barriers, facilitators, and needs across all three studies. Shared barriers included financial strain, low mental health literacy, stigma, cultural skepticism, lack of trust, and limited access to providers. Each group also surfaced unique barriers. The literature cited broadband access and geographic isolation. Providers pointed to regulatory and policy constraints, and community members discussed generational trauma and negative prior experiences. On the facilitator side, all groups emphasized culturally relevant education, faith-based and community-centered care, and the importance of community engagement. We also saw a few standalone facilitators, telehealth in the literature, integrated service delivery from providers, and crisis-driven motivation from community members. And when I say crisis-driven motivation, think about urgent personal events pushing people to seek care. Across all the studies, participants raised similar needs and challenges, from systemic inefficiencies and gaps in continuity of care to deep-rooted stigma. Community members also emphasized the need to first meet basic survival needs before mental health can become a priority. And one striking insight that I found, community members, they called for crisis response alternatives. So someone to call other than law enforcement. And providers stated that those resources do exist. We know we have 988, right? But there's a disconnect in the communication because that message isn't reaching the people who need it the most. This slide distills cross-study findings using a multi-level impact framework that integrates the ecological levels with the social determinants of health domain. Each level reflects how issues were described in the literature and participant data. So some key cross-cutting insights: trust, relatable care, and cultural relevance were core needs across all studies. Financial strain at the individual level, limited access to care and stability. Inadequate mental health literacy at the community level pointed to a need for culturally tailored education to combat stigma. Systemic inefficiencies at both organizational and policy levels were consistent barriers to care, while diversity, equity, and inclusion-informed practices supported more equitable service delivery. Geographic isolation and travel distance emerged as major logistical barriers at the community level. And within the social and community context, themes of stigma, cultural constraints, and a strong need for community engagement were echoed across interpersonal and community levels. This research fills critical gaps in understanding mental health service access for rural Black Americans, whose challenges differ from both urban Black and rural white populations. The findings reinforce existing literature by highlighting key barriers like cultural mistrust and accessibility, while also emphasizing the importance of culturally tailored care, faith-based support, and community engagement. Finally, the call for policy advocacy and systemic change, including telehealth expansion, underscores the need for sustainable, equity-driven solutions. All right, now I'll discuss the implications of these findings and key recommendations to address the challenges identified. So this slide outlines actionable public health strategies to address disparities and promote sustainable solutions. And I did want to highlight just a few. Culturally tailored interventions are essential. Training must reflect the unique cultural and historical context of the rural Black communities or the rural communities or whatever community you're serving. It needs to reflect the community that it serves. Systemic and policy barriers are needed to be addressed through equitable resource allocation, telehealth expansion, and legislative reform. Community engagement and trust building are also critical. Partnering with faith-based organizations and local leaders can help create programs that resonate with lived experiences. And then finally, faith-based solutions provide trusted spaces to normalize mental health care and reduce stigma within that community. In addition to the broader public health strategies I just mentioned, here are a few practical steps that we can take right now. Normalize mental health conversations using familiar, accessible language, framing it around wellness, resilience, or strength. Engage trusted messengers like pastors, peers, and community leaders, people already rooted in that community. Create culturally safe communal spaces for healing, learning, and connection. Invest in rural mental health workforce retention and support. And then also utilize proxy advocates. These are the people with lived experiences or trusted community roles, and they are key to bridging that gap. They help to reduce stigma, increase awareness, and normalize care in spaces where people already feel safe. Ultimately, the most sustainable solutions are those that emerge from within the community and are led by the people they are meant to serve. I want to say that again. The most sustainable solutions are those that emerge from within the community and are led by the people they're meant to serve. Looking ahead, future research should explore the long-term impacts of community-based mental health workers, proxy advocates, and culturally safe spaces on mental health outcomes in rural Black populations. There's also value in examining intergroup dynamics between rural Black and tribal communities to better understand how implicit bias affects access to care. And then finally, longitudinal mixed method studies with diverse, statistically significant samples are needed to capture shifts in service delivery and track evolving attitudes and needs over time. This research highlights the urgent need for culturally tailored interventions in minority mental health. By examining the intersection of race, geography, and systemic factors, we see how these overlapping elements contribute to poor mental health outcomes and why a multi-level approach is essential. Improving access means addressing barriers at the individual, organizational, and policy levels. By integrating insights from the literature, provider perspectives, and community members' experiences, this study offers a pathway forward rooted in cultural humility, community engagement, and policy change to increase service use in rural Black communities. And to tie a bow on this, public health is about trust, not just treatment. Systems change when stories lead the way. Equity begins with listening and acting locally, and health equity starts with empathy. And we each have a role in building systems that are more just, more humane, and more responsive to the people they're meant to serve. Thank you all for spending part of your day with me. I really appreciate your time and attention. Feel free to reach out whether you have questions, want to connect, or just want to keep the conversation going. My email is on the screen, and I also love to stay in touch on LinkedIn as well. And I just want to leave you all with this. As we celebrate National Public Health Week, don't get discouraged or lose heart. Even in the face of today's challenges and the ongoing war against public health, our work matters. Your work matters. Keep fighting, keep showing up, and keep centering equity. Thank y'all again.
Thank you, Dr. Hudson. One question. And it involves trust, as you stated. Thank you so much for a great presentation. Since you can't surge trust, you can't make it happen in a quick manner. What was the average length of time from, say, zero to experiencing trust it took for you to establish trust based on working with these communities? For instance, the mayors, the tribal leadership, the communities impacted. How was your experience around the time it took and some of the things along the way that are memorable for you?
Yes, absolutely. For about 1.5 to 2 years, I traveled to their bi-monthly coalition meetings, and these meetings rotated in each of those towns for each month. So I was all over Oklahoma traveling to these bi-monthly coalition meetings. I also attended any conferences. I asked to be present at any town halls. I really immersed myself in the community for about 2 years before even starting this project. And that was one for them to see me and get familiar with me. But also, I hate when people only come to you when they need something, like that's the first time you hear from them. So knowing that I was going to ask them to participate in this research, I wanted to make sure that they were getting something from me as well. So anytime they had community service events, I showed up. But yeah, it was definitely about a 2-year process trying to establish that trust with that community.
Thank you.
Mhm.
There's a question from Dr. Robinson. What are some ways we can encourage people to step up and be leaders when life in general can be exhausting?
Some ways we can encourage people to step up and be leaders. Well, I'll start from this experience. I think just storytelling, sharing your story. A lot of people they think that this is something that we have to keep closed and closed doors or only talk to God about it. So I think just the more that you're sharing your experience and storytelling and testimonials, it'll break down those walls and people will be more encouraged to speak up and also seek out help. But I think the leadership is already there. You just have to have the courage to speak up on it. It's not who is the leaders that can save us. No. What's your story? Tell me about it. How can you relate to me? Let's get on, let's get on a personal level and let's just share and talk about what's going on.
So building on that, I know Dr. Smith is formulating a question as we speak. Building on that, your comment around, which is appreciated, around the state of affairs regarding public health in the U.S. and around the world right now. How do you encourage people who feel that they don't have a voice? How do you advocate for advocacy and activism, from a public health perspective?
Such a loaded question, Dr. Simpson. Um, I mean, this is kind of in me now. I see the disparities. I see my community, the rural communities, the Black communities, and I can't be quiet. And I know I might get in trouble for saying certain words like diversity, but that's what's needed. So I guess just having the courage to stand on and stand firm on what you believe and what you know is needed, and let the people know that, hey, you have a champion out here fighting for you. I'm gonna do as much as I can. We might not have all the funding, but we have voices and we can get our voices out there. And hopefully that'll spur some more funding or whatever resources we need to come our way. But just don't just lay down and be quiet. You can't stop talking. You can't stop fighting. You can't stop advocating.
Thank you.
Hmm.
So
Any
Dr.
other
Smith asked,
questions?
yes, one more. Can you share the process of engaging communities of faith who may be resistant to efforts to address health and equity?
Yes, this came up a lot. So one strategy would be to connect with the faith leader, youth pastor, whoever is the head, and get their buy-in. They are the gatekeepers for the faith community. Another thing is using the Bible, using scripture. You would be surprised how many analogies and metaphors we got from the scripture to pair with mental health. So there's a training called Mental Health First Aid Training, tailoring that to the faith community. So there's different ways that we can take what's already out there and just kind of culturally tailor it to the community we're trying to serve. But definitely tapping in with those faith leaders, the community leaders, those are the gatekeepers to that community.
Excellent. I like the quote that we should, certainly in public health, it's applicable. We should speak their language, not mine. And that's exactly, I think, as you described, how to do that, regardless of the community, whether it's faith-based or otherwise. Are there any other questions for Dr. Hudson? Seeing none, we will wrap it up for today. And thank you all for your time and attendance, and look forward to seeing everybody back tomorrow at noon. Thank you again, Dr. Hudson, for your time.
Thank you.
And very well done.
Thank you. Thank you.